I've come to the phase of my career where I don't have to speak anything new. I just can go back to the physiology, and younger guys like Lucas Brander then show the real stuff. Let's first start with the physiology of pulmonary circulation, which actually is a circulation of interactions. It has interactions between the circulation itself and gas exchange, interaction between the circulation and lung water, interaction between the circulation itself and the heart, and finally, my current topic, the heart-lung interactions, which is basically the effect of interthoracic pressures on the circulation and the heart, and the interaction between the two hearts themselves. And of course, to make things more complicated, all these items can interact with each other. So we are really looking at a fairly complex situation that we are talking about. Let's first look at the prerequisites. Basically, we talk about an intrathoracic circulation between two pumps, and all this is connected with the systemic circulation, which is mostly outside of the thorax. We have low resistance, high compliance, high flow, and low pressure. The pressure swings, even in health, are fairly large in relation to intravascular pressures, and when the patients get sick, these may even be much, much more enhanced. We have two pumps that are in series, which means that basically for the left heart to fail, the right heart has to succeed. And if the right heart fails, it doesn't play any role how well the left heart functions, because it doesn't get what it should be functioning on. At the same time, these two pumps are in parallel. There's a common septum, there's a free ventricular wall that has common muscle fibers. The heart rate is usually the same for both, as we know, and they have the same functional cycles, more or less. And the basis for the interactions is that we have different pumping conditions for the two hearts, and there is this simultaneous parallel and serial coupling. The functional interaction occurs in both systole and diastole. For the right heart, the rate of venous return varies much more as the one for the left heart. Ventilation modifies the right atrial pressure, and the pulmonary circulation, where the heart is ejecting, has a low pressure and high compliance. Whereas for the left heart, the opposite is true. There is a low rate of variability for the venous return. The pressures are higher, and the circulation where it ejects has high pressure and low compliance. So which influences should we consider? Clearly, venous return, the right ventricular ejection, left ventricular filling, left ventricular ejection, and if you put it together like Guyton used to do, so we would start with the venous return. Venous return is dependent on the right atrial pressure and the systemic circulation filling pressure. The systemic filling pressure. The difference between the two is the driving pressures for the venous return, and if we reduce the pressure in the right atrium low enough, then we will come to the situation where the veins are collapsing, and then that's the limiting factor for the venous return. But above that level, there's this driving pressure gradient, which is creating this relationship, which can be drawn as schematically as a venous return curve. The heart as a whole, if you consider the heart as a whole and its function, then at a given level of venous return and a given cardiac function curve, there is one cardiac output. When the pleural pressure decreases, the function curve shifts, And when it increases, it shifts once again, and the intersection points between the venous return curves and the cardiac function curves determines the momentary cardiac output. If in these circumstances increase the mean circulatory filling pressure, for example by volume challenge, then we shift the venous return curve upwards, and we can see that we have a new relationship where the changes in pleural pressures create new levels of cardiac output. And this increase in cardiac output indicates that the patient is, as we would say now, volume responsive. This is now extensively being used for hemodynamic monitoring and treatment of patients, and I would like to emphasize it's been extremely also misused, and we will come back to that just in a few minutes. This shows you a flatter cardiac function curve. Now once again here, if we look at the changes induced by changes in pleural pressure, we can see that because of the heart is functioning on its flat part of the cardiac function curve, we see no changes in cardiac output. Now in these circumstances, if we would increase the mean circulatory filling pressure, we would see no increase in cardiac output, but we would see a higher right atrial pressure. We would say this patient is not volume responsive. If in this circumstance we would then increase further the pleural pressure, we could see the shift in the curve, and if the venous return curve is the original one, we would see a decrease in cardiac output, and then we could actually expect that if we would increase the mean circulatory filling pressure in these circumstances, we would be able to restore the cardiac output. Now this simplified scenario of respiration-induced changes in stroke volume or more commonly in blood pressure have been extensively used to promote a concept where we could just looking at the pressure, arterial pressure curves during mechanical ventilation, and we define patients who are volume responsive and those who are not volume responsive. And in fact, if you look at the data that is available, we can see that there are a lot of patients. Less than 60% of patients have been defined as responders, but in fact there are just a few studies in ICU patients, and those are not perhaps that convincing. It took a few years to realize that the physiology is working also in these patients. Nothing is so simple, and this paper came out a couple of years ago looking at patients who had this heart-lung interaction indicated as pulse pressure variation, and who were given a volume challenge, and the investigators had altogether 35 patients in 6 months, which from my practice would be really a very, very small number. But anyway, they looked at the physiology in these patients, and they saw that there was a big false positive rate of this pulse pressure variability, and the explanation is actually clear if you go back to the old physiology. The explanation must be right ventricular dysfunction, because obviously the so-called volume responsiveness is not the only mechanisms by which you can create pulse pressure and stroke volume variability. The alternative obvious mechanism is right heart dysfunction, and I will come back to that. We were postulating that for earlier on. Perhaps 2 of the most difficult papers in my life I've ever published to get published were two papers which challenged this concept of using pulse pressure variation for volume challenges. And because we found in patients with pulmonary artery hypertension and also in an experimental setting reproducing that indeed right heart dysfunction gave you pulse pressure variation which suggested volume responsiveness, but the animals or the patients were non-responders. Nobody wanted to read that, nobody wanted to publish that, but that's unfortunately physiology behind these findings. It could have been seen in the literature if anybody would have found this reference. I have the reference, I have the pictures, but I can't find anymore where it was published. But it was published a long time ago from Michael Pinsky when he was still a young man. What is shown here is a plot of right ventricular and pulmonary artery pressure curves superimposed with airway pressure. And these arrows, the pink arrow above shows the tidal volume, 300 cc's. Right ventricle and pulmonary artery pressure curves are shown there, denoted by these two arrows, which show the values in end experium and peak in sperium, and the arrows are the right ventricular isovolumic pressure change. That means the pressure that the right ventricle needs to create before the pulmonary artery valve goes open. So that is the contraction that needs to be generated for the blood flow to start from the right ventricle. It is an indicator of right ventricular afterload. When you increase the tidal volume, you can see that what is happening is that the right ventricular afterload increases. Interestingly, if you look at this graph very carefully, you can see that there is a phase shift in the pulse pressure variation here, indicating that different mechanisms come into play when the right heart is being strained to its limits. So, if you look at the easy explanation for heart-lung interactions is to focus on the preload, because when you increase the intrathoracic pressures, you are decreasing the preload of the right ventricle and also that of the left ventricle. But let's look at the afterload. So we saw that when we increase enough the pressures, we are increasing the afterload for the right ventricle. The preload reduction reduces the end diastolic volume, but the squeeze on the vessels and increased outflow resistance intrathoracically increases the right ventricular end diastolic volume. This can be counteracted if the increased intrathoracic pressure is recruiting more lung units and therefore increasing the capillary area. So these two mechanisms are opposing, and depending on their balance, the impact on the circulation is different. Therefore, we cannot predict the effects. Let's look at the thing schematically. The left heart decreased preload. If we have a dysfunctional left ventricle, we will have decreased preload and at the same time a reduced left ventricular outflow resistance. And why is that? The explanation is simple. In contrast to the right ventricle, the left ventricle ejects in the aorta. And the aorta ends up extrathoracically. We have decreased transfemoral pressures due to the increased pleural pressure, and therefore we have an advantageous impact on the left ventricular ejection. This is actually a mirror image to an intra-aortic balloon pump, looking from the inside of the thorax in contrast to looking from the inside of the vessel. But the physiologic impact is the same. If you have a right ventricular dysfunction, a dilatation of the right ventricle causes a shift of the septum, and therefore, at constant filling, the left ventricular end diastolic volume will be smaller, and if the function remains the same, then the left heart cardiac output will be reduced. If the patient is breathing spontaneously, the inspiration increases the venous return and therefore further increases the right ventricular dilatation and the septal shift. On the other hand, if we reduce the preload by mechanical ventilation, it is possible that this decrease in venous return has a beneficial effect, but at the same time, there is the risk of these afterload effects, because at a critical level, the increase in afterload starts to overcome this beneficial effect of reduced preload. The predisposing factors are not that uncommon in our patients in the ICUs. Volume overload, lung hyperinflation, and also an acute pulmonary hypertension. This is not just theory, this is also all data from V.R. Baron and Jardin. If you look at this echocardiography, and these are now the left ventricular and right ventricular curves shown here, and you can see that here the septum has its normal curvature from left to right. Now if we do an acute increase in PEEP, this is a very high increase in PEEP, 20. From 0 to 20, this is certainly over exaggeration. So what you can see here, in contrast to these curves, these pressure curves shown here, you can see that here, in the end of the ejection, there is a shift in the curves so that momentarily the right heart intracavital pressure is higher than that of the left. And therefore, what we can see as the end result is that the septum has to shift. This is simple physiology. The pressure change towards the end of the ejection causes now here the relative tamponade of the left ventricle. So dilatation of the right heart can therefore reduce the stroke volume of the left. This can be partly corrected by, for example, fluid loading or vasopressors which influence the capacitance vessels, but the cost of that is a further dilatation of the right ventricle. And that explains why in pulmonary hypertension there is a poor response to fluid loading. Now, if we have, in contrast, just a cardiac compression due to spontaneous hyperinflation, for example, or mechanical ventilation and PEEP, then we have a compression of both ventricles, and fluid loading can be expected to restore at least partly the end diastolic volume of both ventricles and therefore the cardiac output. There is an additional interaction in the systole, which is poorly understood. There may be a direct mechanical interaction between the two ventricles. And of course, if the coronary perfusion is critical, then also the systolic interaction becomes critical. So the good left ventricular ejection contraction can aid the right ventricle. This explains why sometimes if you, in patients with a right heart failure, you made the mistake and put an intra-aortic balloon pump, they may actually suffer hemodynamically. So just to summarize briefly, so for the right ventricle, an increased intrathoracic pressure increases afterload, and for the left ventricle, it decreases the afterload. To summarize my talk, venous return, cardiac function, and intrathoracic pressures do interact. There is an interaction between the ventricles, in diastole from right to left, in systole from left to right, and the interaction depends on the degree of loading of the right ventricle, especially on the venous return effects, and secondly on the afterload effects. Thank you very much.